I've always enjoyed the discourse, and of course my tremendous respect for the RNAO. So, so I'm here, and I thank you very much for the opportunity. I know it's been a kind of challenging year for everybody in healthcare, but I would just call out the tireless work of NPs and nurses across the province has obviously made a huge difference for patient in hospitals, residents in long-term care homes, and anybody in need of care in the community. And it's been a heroic effort. And, on behalf of myself, my family, and of course the ministry, I just want to thank everybody for what they've been doing, and to see the energy in the room. Just as I kind of dropped in earlier was terrific. This is obviously a group of people who still have some gas in the tank, and I appreciate that very much, and the energy that's brought to the effort, and certainly big shout out to the RNAO for your continued, and Doris in particular, for your continued advocacy efforts. I know you challenge us probably daily at the stakeholder tables, and obviously in the platforms that you have in the province, and we're the better for it. And your advice and perspective are important. I certainly pay attention to what you're saying. I read your weekly emails, your newsletters, and it's hard when you're kind of used to getting out a lot that you can sort of live in the bubble of Queen's Park. I'm actually in the office today, as I have been, I guess pretty much half time since May, but it's really, I think, more important than ever that we listen to the perspectives of people who deliver care in the province. And I've missed very much. If I have one complaint about COVID, other than, sucking every living, breathing moment of my life. But other than that, it's actually the lack of opportunity to meet with in these kinds of forums. And that's the fun part of the job. And I've said, and probably Doris has heard me say this before, or you've been here before, is I learn more from these interactions than you get from me, because I hear about what's on the ground, and I come back to my team and I go, that part of it's not going so well. Or, they really like this, or, there's another problem that we haven't really contemplated, or, we really need to think, like, we're not optimizing the skill mix and the people that we have in the system, and we need to pay attention. So, that's, I guess some observations and thoughts. I'm going to talk a little bit about the transformation agenda, and I did ask my team coming just to give me a list, and it was pretty long actually, about the role of NPs in the transformation agenda. And I probably won't read all the contributions, but they are substantial and they are important. And I would say, before the pandemic, we were in the middle of a system transformation to address, what I think two linked issues. One is, system capacity. And we've seen some of the issues before and during the pandemic, and then the fragmentation in the system that was negatively affecting outcomes and the patient experience. And so I think I don't have to go over the challenges, but certainly challenges with appropriate mix of services. We might not have had optimized digital tools to meet I guess the demands of the modern day patients and their families, and of course capacity pressures, and certainly the ALC issue remains an important issue with patients cared for prior to the pandemic in hospital hallways, wait lists for long-term care exceeding 30,000 people in normal circumstances. And as I say, we've got about 4,000 hospital beds being used for patients who could be cared for more appropriately outside of the hospital. And we had occupancy in many parts of particularly the Greater Toronto area that were exceeding 100% on a regular basis. So, I would say, hallway healthcare, although we haven't talked about it much, is still, I think, something that we need to get back to in terms of capacity planning. We also heard about, families having difficulty navigating the healthcare system and waiting too long for care, and the negative impacts on provider and caregiver well-being. And certainly as we sort of come out of wave one and are able to resume elective surgeries or scheduled procedures, I guess is the better terminology, and looking at even some of the deficits in primary care in terms of, preventive care that has not been provided as in-person visits, I think, have been reduced. There's a whole lot of catching up that we need to do, and we pay a lot of attention, and because we can count it in about the numbers of particularly orthopedic, cardiac procedures that haven't been done. But I'm also as concerned about the primary care. The percentage of Pap tests that have been done this year versus last year. And I wouldn't be a graduate of Cancer Care Ontario if I didn't look at, Pap test, mammography, and colorectal cancer screening. And, that's just to name a few. I would say that, there's certainly, there's an agenda that was identified, the People's Healthcare Act 2019, for those of you who follow it. And I think, the plan still is to get the funding and the supports out to the front line so that healthcare providers can do what they do best, which is care for patients. And so, you'll see us, hopefully, while COVID has really consumed, I think, us here in the ministry and the whole sector, there are people who are still working on, looking at system capacity, looking at, a longer term plan to end hallway healthcare. In the fall plan, for example, we've added about 2,300 beds, I believe, to the system in order to, deal with, and that's the sort of moderate scenario. So again, looking at, trying to make sure that we've got the capacity where we need it. I noticed that you did have a section that reflected a little bit on COVID. Ontario Health has certainly, had its detractors at the beginning. What's the use of having, a big agency? The cancer system, I think, was very concerned about being swallowed up in a large generic health agency. It has been critical. When I think about, we didn't know at the time that we were heading into the kind of waters that we found ourselves in, but the ability to translate, programs in on the ground and not have to negotiate that with 14 LHIN boards and 14 LHIN CEOs. And, we did not have what Alberta had, which was, a single email system for all the providers in the province, or a single lab provider. A single lab provider served Alberta particularly well at the beginning, maybe not so much at the end when they actually started running out of, some of the swabs and reagent. And because we had a diversified set, it actually worked pretty well. But we had to put a lab information system in on the ground really, really quickly, and having kind of the unified leadership of Ontario Health, has been phenomenal. And having, for me, a colleague in Matt Anderson, who is, able to sort of translate some of the directions from the government into, an active response on the ground and engaging through their regional offices, the providers and communities that need to be engaged to mount that response. I think, we couldn't have done it any other way, but they've got other work to do, right? I think that's also important in, trying to bring, consistency across the healthcare journey, and across, not only in cancer and renal care, which is where I worked in both areas, but in mental health, in the use of digital and virtual health, improving clinical guidance. And I know you have a whole program, and hopefully they will collaborate with you as needed. And support for providers, across a range of conditions and age groups and everything else. And so, I really look forward to them being able to sort of step up. And I think the one area that probably excites me most, because it's where I started my career in healthcare, is working on trying to get housing and support services to work together for people with mental health problems as a young analyst, and then spent about 4 years working in the mental health part of the Ministry of Health. And so the Mental Health and Addiction Center of Excellence and the possibilities that it brings to really, hopefully have kind of leapfrog improvements in mental health quality and access, I think is huge. And of course, Ontario Health will play a big role in Ontario Health teams, and I think everybody probably knows what they are. But really, I think, we've announced more recently. It's still an idea that I think, has great resonance in the sector, that will allow us to bring things like care coordination closer to the point of care, get people working in a much more integrated way around patients. We've got some work to do on sort of what are the governance models, but I'm optimistic that those can be worked through as the Ontario Health Team idea matures. And certainly bringing a broader group of, providers into the family, and certainly, primary care, the nurse practitioner-led clinics are certainly part of the, I think, part of the success of Ontario Health Teams, and really look forward to sort of continuing that transformation. To be fair, it's the part of the job, that I'm probably better suited to than running an emergency response to a pandemic, and I enjoy the opportunities I've had over the last few months to dip back into the work of transformation, and so I'm hoping to be able to spend more time on that in the future. The other area that might be interesting, and again, it's one that I don't know a lot about personally, but it certainly makes sense to me, is really trying to also integrate the supply chain. I think, for those of you who kind of followed it or were worried about the availability of PPE, as I think we all were, I think I lost more sleepless nights, had more sleepless nights in the spring, just wanting to make sure that we had what we needed for the frontline providers, including my niece, but not, but far beyond that, of course. I think the efforts of the government to build domestic production capacity, that we have N95s that are going to be rolling out of a plant in Brockville, and we will never be, require, calls in the middle of the night, because we might have a plane that might be in Shanghai that might be able to get PPE. We've had, manufacturers step up and build and make gowns. We've had, surgical masks being made in Ontario. I think the only one that we have a challenge with making in Ontario is gloves, and because like 90% of the world's supply is built in Malaysia, and even there, I think we have some ideas and some entrepreneurs coming forward. And so when you start to kind of deliberately seed domestic production, you have to buy it. Right? I mean, it becomes really important that you've actually got to purchase it and put it into the system, and you've got to harness the purchasing power of the system, of the healthcare system, and frankly, it goes beyond healthcare into schools and other places. So that's maybe it's kind of like the back office transformation of the healthcare system, but it's actually pretty interesting, and it's really important, and it will make sure that we've got what we need, and it will go from pacemakers to bandages to computer to IT, computers in schools, everything. So I think that's pretty exciting. Home and community care modernization. I'll just say I know that the RNAO has been tireless in its advocacy around what should be done about home care, and I think that there's a shared objective about moving care coordination closer to the point of care, including primary care, and really trying to make that much more part of the care team than it has been. I would say, it's been interesting for me to watch, I think, many of the care coordinators, some of whom, had not been at the front line and had been working, basically in front of computers, making arrangements for care. Many of them stepped up during COVID and actually got back out there. So that's kind of interesting to me to see, you know, maybe having had that experience, this transformation of home care might be a little bit easier. Hopefully we whet their appetite about what it can feel like to be part of an integrated team. And of course, mental health, which I've talked about. So don't go too long, but I think I miss, as I say, it looks like you're recording this, so I may actually ask to see if I can see the session on, you know, what was learned during the pandemic from a nursing perspective. I think that would be enormously interesting. And certainly, you know, we've had to change how we work, how we organize ourselves as a ministry and as a government. Many of the things that we are, you know, traditionally would have fallen to the ministry have also had all of government responses. And so, we, you know, work on vulnerable populations was led by another deputy. You know, as you know, we have a separate Ministry of Long-Term Care. We have work on certainly outreach to our Indigenous citizens and population in the province. And so I think, you know, that has certainly, you know, I think been challenging but important. And, you know, as I look forward, and today's the day that we've announced Rick Hillier as General Hillier as the he's going to be like the sort of commander-in-chief, I guess, of the task force that's charged with the vaccine. And you know, I met with him on Sunday. I would say he's certainly, you know, you sort of think the generals are going to be very formal, but he's actually a good Newfoundlander. And that's a very attractive thing, because he's got sort of that nice sort of self-deprecation, but obviously mind like a steel trap on logistics. And he's going to perform a challenge function for us, kind of like you have been doing, Doris, but, you know, in terms of the execution of the vaccine. And so, you know, I'm pretty excited about that. I think, you know, it's kind of hope on the other side of 2020. I don't know, you know, when those vaccines that have been in the newspaper are actually going to arrive in Ontario. We're going to have some heavy lifting to prioritize the folks who get it first, given the numbers that have been reported. I would say healthcare workers will be pretty close to the top of the list, I would imagine, but there may be some properties of some of the vaccines that require that they be used in certain populations or counterindicated for some, and a different efficacy, different delivery challenges. The minus 70 degrees for the Pfizer product kind of gives me indigestion a little bit, but some of the later ones are going to feel a lot more like a flu vaccine. How we count this, how we work with our workforce, how we deliver it, I think are all questions that I'm sure we will get good advice on, and we will be ready in September, or sorry, in January. And I think that you know, we'll work on this as we always do together. And you know, I'm hopeful that this will be another proof point that the only way that we can, you know, deliver care that is of a, you know, consistent high quality, that really meets the needs of patients and their families, is through collaboration. And I think that this program of vaccines and the balance of the transformation agenda that will go on, you know, past the end of my career, will reinforce the need to continue to break down silos, listen to each other, and find new ways of working together that really optimizes every member of the team. And I think in that, we certainly have, I think, a shared vision of where we want to go. So I'll stop there and look forward to any questions or comments. Would certainly welcome that. Oh, I can't hear Doris.
I'm sure my colleagues will want to ask questions. So let me just make a brief comment because I get more airtime with you than my colleagues. I will let that to them. So first of all, thank you again. And you do know that you have a partner in RNO. Yes, to raise the difficult questions and also to do the heavy lifting, both of the above, and more the latter than the first. Also, I heard you say about the vaccine in terms of healthcare workers. What on behalf of RNO, what I want to be assured for certain is that long-term care residents will get it first, and not like the PP that they got it way after,
Yeah.
because already it's a disaster in that population. So I think families need to hear that soon. That's the case still, right? That does not change.
That's the general guidance that the federal government has pulled together based on the immunity task force and everything else, suggests long-term care residents. I'd like to make sure that the vaccine that's coming first is good in immune compromised populations. There's a few things like that, but clearly the group that needs it first are the people who are at risk of terrible outcomes from if they get COVID.
Fantastic.
And then the vectors, I think you're more than a vector, but it's the people then who interact with them. It's kind of like going out in circles. And as it turns out, from what I've seen so far, is that none of the vaccines yet have had clinical trials in children. So that's also will be an issue, is how do we deal with the kids and what's the level of evidence? So, it's not uncomplicated, but I think there's also, you're right, Doris, there's some things that are just so self-evident that, it's not even worth debating.
Yeah, the other thing, just to comment for my colleagues, and I know you are aware, our work with Ontario Health Teams is fantastic. And I need to tell you, heavily involved in since the inception with 4 of them. 10 are waiting to come on board. So here you go. And it is excellent, the work they were doing during the pandemic. We are involved with East York and with others. Absolutely excellent work. And implementing the guidelines in the midst of the pandemic, not only in terms of vulnerable populations, which many of them did fantastic work helping one another with PP, etc., but also dedicating time to the ongoing work of evidence-based practice. It was really inspiring to see that they could find the time and the energy to do that. Yeah. Similarly, I do hope that the basic care guarantee, which the commissioner is very interested, and finally, there is consensus by all the partners related to nursing homes. Let's hope that we don't move in 4 years. Let's hope that we move in 2 years, because otherwise we will see a whole generation of seniors really. With that, I will open to questions, and let's look at the chat. Our colleagues, Lillian, you want to ask your question? Is related to more rapid testing and issues of contact tracing, if you want to comment on that.
Sure, I can, absolutely. So there's 2 rapid tests right now. I think more are coming. They have to go through Health Canada first around safety and efficacy and that kind of thing. The first one, there's one called ID Now, which is like PCR in a box. It's like a toaster. It's pretty accurate, has a pretty slow throughput. So it does, a couple an hour. And we've started to send those out across the system. Initially, because they sort of have to be in a quasi-lab environment. They're not very mobile, even though they are a toaster. So the big lift is to get them up north. And we're kind of starting to put them into hospitals and places as a kind of central place to put them, where turnaround times for the standard PCR are really high. So that's a pretty good one. We haven't got as many of them as we thought we were going to get, but more are coming in December. The other one is called Pan Bio. It's an antigen test. It's got some unique properties where it's if you're not expecting a lot of COVID, the negatives are true negatives. It's got some false positives in there. So I'm kind of pushing my team to look at, if you get a positive, maybe you send them over for the ID Now really fast. And so you can sort of decide whether it's a false positive or a real positive. It comes with a nasal pharyngeal swab at the moment, but Abbott has put in for the nasal swab only. So when that happens, it'll be much more useful. And we now have guidance about how to use it in outbreaks. So I think you're going to see us using the Pan Bio a lot more. And we've changed some of the regs around it so that it's easier for a range of professionals to use it. as opposed to kind of requiring, you know, physician and that kind of thing. So that's brand new from Friday. On contact tracing, you know, it's an interesting, because I totally agree. And I watch Twitter too, test, trace, and isolate. And the tracing, I think, has been a challenge, particularly, you know, like in Toronto, a little bit in Ottawa, a bit in Peel. The others are kind of keeping up. We created a central pool of contact tracers, and there's kind of two types, right? There's the case investigators, and then there's the contact tracers. We're trying to automate as much of that as we can, not the investigation part, because that really does require a nurse and somebody with skills and interviewing skills and clinical skills to do that. But the follow-up, I think we can automate. We're also trying to get people to enter their own information about their contacts, as opposed to doing that in as labor intensive a way as we can. But we've got a pool of, you know, hundreds of contact tracers, and we're deploying them across the province when public health units get into trouble. I think there's a tipping point, and you know, somebody can argue with me. I think there's a tipping point that when you get to about 60 cases per 100,000 or so, that you kind of hit the wall, and you're just over. All contact tracing pretty much is overwhelming. You've got widespread community spread, and those are the numbers. And you know, obviously we're in lockdown in Toronto and Peel, and hopefully that gives us a chance to catch up and, you know, drop the numbers. It didn't happen today, and it won't happen tomorrow, but it will happen hopefully over time, and then we can get back to business. And meanwhile, you know, increase the workforce. But it's kind of it's the IT and the automation that has been, I think, pretty critical. And then, you know, there's a few relationship issues with 34 health units, as you can imagine. Some are a little more welcoming of central support than others. So there you go.
Thank you. Deputy, meanwhile that my colleagues identify the next question, I have one. Is there any conversation both in at any of the tables, and you would be the first one to be aware, of taking a COVID-0 approach? Because, as you know, our NEO has been a bit vocal about this, and we are involved with the larger group now that will become larger.
Yep.
And this week you will hear more about that. But it just, I wish that it would have occurred to all of us, quite frankly, in May, June, when the numbers were 100. But the problem is, if we don't take that aspirational approach there, we're going to be in a third and in a fourth wave, and people will be exhausted. They're already, I mean, all these lunatics that you see of crowded, no mask, this and all of that, is just because people are exhausted. But people are exhausted. And the danger, if we don't really take a different approach, right, of suffocating the virus, it's kind of scary.
Yeah. I mean, I think throughout this, we've had to tack, you know, in different ways at different points in COVID. And, you know, once we vaccinate, I mean, I don't know if the numbers are exactly right. I mean, these are sort of planning numbers that have been put out there. I wouldn't take them to the bank, but, you know, if we can vaccinate 10% of the population of Ontario, or 8% of the most vulnerable, what does that mean? You know, and what's the tipping point? So, I mean, I just think we have to stay as nimble as we can and be as ambitious as we can. And, you know, I think that, and Staney Brown has made this argument very well in venues that I've seen him speak in, that, you know, tapping down COVID and getting very, very low, if not to zero, and economic prosperity are actually fully aligned.
So that, I don't know if you had the chance, I will make sure that we send to you our press release in relationship to the lockdown, because our view is that, well, first, that we started late all along, and as you know, some of us were pushing, but you cannot go back there. But we still can go forward. Before the vaccine will take a lot of time. And the forward means to do these lockdowns or whatever is needed way faster and more strict, so that you really, again, have a different approach of COVID-0. It's not after the vaccine, it's before. And it's a lot of epidemiological data that supports that. So any conversations of that at the government?
Yeah,
I know the premier is afraid, not afraid, he's very mindful of what the pressures he gets from the business community. But
yeah.
the problem is the business community will be more damaged if we don't do more faster and strict measures sooner. Because
Yeah, I would say, I think the premier's always been pretty attuned to the public health side, and I know he gets a lot of pressure on the business side, but I would say, he's stuck with it. I give him a lot of credit, actually.
yes, yeah.
And I think, the things that we might know from reading and looking at other jurisdictions, and we now know from experience, right? We know how sneaky this virus is and how it gets into places, how quickly, what a super spreader event is and everything else. And so I think, there was maybe on all of our parts, and probably I'm sure not on yours, but, there was a day in August, I think we had a few debits, but there was one day in August where we were at 33. And I think there was a bit of a data correction. So the real number was probably in the 60s or something. And I remember saying to Matt Anderson, I was like, we were really smart, we quit today. But we didn't. We're not that smart, and nor is it in our DNA not to stick this one out. But and so I think there might, I don't know whether there was a sort of a sense that maybe we could be different. And I think we now know we're not different, right? That this virus has not, the trajectory of it has not changed. All we can do is alter our response to it, because its properties are the same today that they were in February and March. And so that, we're learning which strategies work and how it spreads. And so that's certainly challenging. I don't envy them having to weigh those, and we give them pretty good health advice. And I think, there are many things that go into a government decision.
On that, Deputy, I am on the same page as you. I don't envy any politician, any premier or leader of jurisdiction, whether this party, that party, or that party, anywhere in this country.
No, terrible. Nobody's, people are going to, there's an auditor general is going to come out with, audits on this. And, I'm sure in hindsight, and everybody, we could have been very prepared. And, I'll take that. But I don't know that anybody was fully prepared for this particular pandemic.
Well, we remember my conversations with you about Italy and Spain.
Yep.
So we could have started before, but we can't go back. But
Right.
what we can is go forward. And now we know. We know the virus doesn't take break for lunch, doesn't take weekends, doesn't even sleep the damn thing.
No, it's terrible. Right? It's terrible.
So that's why the sooner we suffocate it by very strict and fast measures, those measures will last shorter. And it's well known now in epidemiology.
Yeah. And we got to keep the borders closed, and we got to test people at the borders coming in, because, that's
thank goodness for the federal government we have, I must say.
Yeah, some leakage still happens there, and there's some interesting pilots about the border, but, I think we got to up our game there for sure.
Well, Windsor and other cities too, right?
Yep,
any
Niagara.
Questions, Catherine, Irma Jean, that you can see in the chat?
There don't appear to be any more questions, Doris. I think we've addressed them all.
Nice to see you.
The deputy gave a great update. So thank you. Thank you.
Oh my goodness. Thank you very much. I hope you, hope the rest of your session is terrific. And someday we'll do this in person again. And even if I'm retired, you can ask me back.
We will book you in advance, although I need to tell you that we already, this is out of the secret, but now it will be public. The board knows. We are actually planning the next AGM online again. It's in June. It's in June.
Wow.
It's to plan something in person at this stage is almost impossible. And it's a big event. It's 700 people. You cannot plan it last minute.
Yeah.
So I'm afraid to tell you that the next time will be likely also Zoom, but maybe in person if it's October.
Okay, fantastic. Thank you very much.
Thank you.
Thank you. Bye.